Well, thank you very much, everyone, for attending. It's a real honor for me to be on a panel with such distinguished guests. And I'm really looking forward to the discussion of our key topic areas today. So we're continuing some of the themes of the whole conference, which have to do with the usefulness, utility of genomic testing, access, and trust. And so we'd like to just kind of dive into the discussion and talk a little bit about clinical utility. And Catherine, I thought we'd start with you, and if you could kind of give us your views of where clinical utility comes from.
Sure, absolutely. Well, good morning, everybody, and welcome. So I heard a great quote the other day related to clinical utility. They said, "We are strangers in a strange world of a strange healthcare ecosystem." We are strangers in this strange ecosystem. And why is that related to clinical utility? One thing we've been hearing at this meeting is how important it is to have all the different stakeholders involved in genomics be part of the conversation. There's a lot of different groups involved in genomics, and it takes all of them. We're talking about patients, providers, government, industry, payers, but also other groups like lab benefit managers, IT companies, self-insured employers, labs. So we really, to deal with the clinical utility, we know we need evidence, and we also need the different stakeholders to have conversations about how we're going to collect that evidence, how we're going to integrate that evidence, and how we're going to use that evidence.
And Karen, could you kind of take off from there and tell us what your thoughts are about the evidence requirements and the role of the American Cancer Society in that?
Without question. So, at the American Cancer Society, we very much view our lens as representing the 1.9 million Americans every year that hear that they have cancer and view things through a cancer lens from the patient and the family. From the perspective of genomics in the cancer world, in the oncology sphere, it's beyond just, is there evidence of some clinical utility? We've already seen that in the approval of next-generation sequencing to match patients to therapy, and seen some approvals for new oncology agents tied to genetic alteration. So the future is now for us. When it comes to that next level of whole genomes, liquid biopsies for MCEDs, we certainly would like there to be evidence of clinical benefit for new approvals and new integration into the clinical care continuum.
And Sally, could we hear a little bit about your perspective on this?
So as I have been at the conference, I know that I sense a great deal of frustration that we haven't made more progress in getting genomics embedded into clinical care. And I think, one of the very visionary panelists talked about his vision in 10 years is everyone gets their genomic sequence done at birth. And I really feel like the only way that we're going to get integration into clinical care is through demonstrating clinical utility. And it's unfortunately not a sexy process. It's not nearly as sexy as discovery and research and identifying promising biomarkers, but it takes all that evidence generation to show that the tests that we've made or the biomarker we've identified really does improve on standard of care and really does make a difference to how people are going to be treated in any kind of the clinical pathway. And so that is just I was talking with my fellow panelists that we only got an NCD from a national coverage determination from CMS to cover next generation sequencing for advanced cancer in 2018. And if you just think about that, we've known that there have been drugs that were identified way before then, drugs that were developed and made available. So it's a slow process. Freenome is working on early stage cancer detection, blood-based assays, in which we think will significantly improve standard of care. But again, that involves going through the United States Preventative Services Task Force, and they're even slower, and they're more conservative. So it's every 5 years. So I do think that the reason I care about clinical utility is it leads to coverage, And without coverage and reimbursement, I don't believe that we'll have equitable assessment, access to the promise of genomics in clinical care.
And Catherine?
I'd like to pick up an important point that Karen made, which is that the patient's benefit is really important. And I work a lot with payers, and over 10 years, I've seen a shift where payers are paying more attention to patients and what's important to patients. And yes, they still want data on outcomes, as we've heard, but they're also willing to consider this personal utility concept, which is a broader concept of clinical utility. So we are seeing some shift and some understanding of the benefits that sequencing can provide that may be hard to measure at times.
And Karen, I just wonder about where this evidence is going to come from, and what's the role for public-private partnerships, and where do you think the balance of the responsibilities?
Yeah, well, the evidence certainly comes in the form of clinical trial, and you want those clinical trials to engage as diverse a population as possible, as appropriate for as written. So, when it comes to incorporating genetic testing into cancer clinical trials, that, we've been in this for a while and seen some significant success there. But even when there is an indication that comes through, for example, a biomarker that informs as to clinical utility for any particular cancer therapeutic, reimbursement has to follow. A dynamic shift happened last night right here in the state of California. So we've been pushing for a bill in a number of different states that requires states to cover by the cost of biomarker testing for FDA-approved agents. And we've had success in 4 different states of this being signed into law. And unfortunately, last night right here in California, Governor Newsom vetoed that bill. So it is the case that even when something has already gone through this trajectory of clinical trial and shown utility, unless there's reimbursement, there won't be access. I don't know how to put it any more plainly than that.
And Sally, do you think this particular area of technology, have you faced anything that was a unique problem that sort of sets genomics aside or makes it different from other medical technologies? Or is it simply the entry of genomics into more conventional kind of medicine?
I think the big data aspect of genomics is definitely what sets it apart, especially next generation sequencing. When I was deputy commissioner at the FDA, that was the big challenge. And under President Obama's precision medicine initiative, we were tasked to come up with a way to not kill innovation. I honestly think with the FDA, as far as like regulatory hurdles or barriers to access, I honestly, because I would say like 95% of genomic tests are laboratory developed tests that are never seen by the FDA, I don't think that's what I would point to as the barrier. But I do think both for the regulatory body that approves these tests and coverage from CMS and the other task forces, it's the largeness of the data that I think sets it apart in one aspect. And what really sets it apart to me is just how foundational it is as well. But I don't know that it's a biomarker like other biomarkers. They should understand it, but yeah.
Great. So let's talk a little bit about trust in this whole process and how we're going to develop trust. What are the forces that work against trust? And Karen, could you start us off with that?
Well, I think that there's a lot to unpack in the trust issue and and I would turn it around and what are the kinds of barriers that you need to solve for in order to enhance trust. And one has to do with privacy and the persistent discrimination that actually does occur. So, Gina solved a lot of issues for us in terms of genetic testing, again, when it comes to cancer risk or for cancer patients who inadvertently uncover germline alterations as a part of matching that patient to study through genomic testing of their tumor. Gina solved for lack of discrimination in the workplace, solved for lack of discrimination when it comes to healthcare. but it did not solve for lack of discrimination when it comes to life insurance or long-term disability. And from our work with patients, but also before I came to head the American Cancer Society, I was running oncology for a 16-hospital system across 2 states. We had a genetic risk clinic, specifically for men because of the disproportionate mortality associated with prostate cancer in the greater Philadelphia region. And what we saw was a significant reluctance in men who have a tendency to be the breadwinner in a family to undergo genetic testing due to concern about loss of life insurance and loss of long-term disability. So I think there are some policy fixes that we can do to trust the process, because if you're a patient who is being asked to undergo genomic assessment, you certainly don't want to put yourself into a position where you're losing or losing something that's greater than the value you perceive you will gain from undergoing genomic testing. There's a push and pull there. And so if we're really going to increase this as an uptake, I think we're going to have to solve for some of the privacy and discrimination issues.
And Catherine, have you had any thoughts about this particular?
Yeah, I mean, I think it's a huge issue. And people don't realize when they get, for example, 23andMe consumer testing, that those results could later be used, for example, to keep them from getting long-term care or get into a continuing care retirement facility because if they have certain risks. So people have reasons to be afraid. And the other big piece is there have been a lot of publicized stories recently about inaccurate test results. Washington Post, New York Times, about the problems with some labs. And as we heard earlier, the lab-developed tests, most tests are lab-developed tests, and there was going to be regulation of those. That just got turned down. I won't get into the issue whether that's good or bad, but there are some problems out there with standardization and people misusing results of tests, and that has increased the public distrust because they read these stories and they go, oh my God, you know, there are these mistakes being made by labs.
And I know, Sally, you have some significant experience in the area of regulation, and what role do you think that is going to play in helping to foster trust?
Well, I think, again, you pointed out the notion that laboratory-developed tests aren't reviewed by a regulatory body. Some people say they're reviewed by CLIA or CAP, and the processes are, but there's not really. It's just a completely different world. So it's an interesting landscape that we operate in, that we're developing tests in, where some go before the regulatory body and some don't. I'd say like trust to me is multifaceted. There's the trust in the technology and whether that should be standardized and perhaps regulatory. A different form of regulatory oversight might improve that. Trust also, though, is, you know, the patient. Did I participate in the development? Like, does somebody who looked like me, were they part of the clinical trials that tell me this test works so I know it works on somebody that looks like me? That gets into a whole different issue of just the difficulty in recruiting a diverse population when it comes to clinical trials that are used to validate these tests. But that definitely plays to me and is one of the key, does a patient trust this? And then what are they gonna do with the data? What's gonna happen with the data and how much control do I have over the data? Because I am gonna make a risk-benefit decision about like how much benefit will I get out of this test? How important is that benefit, and what's the downside risk of this information somehow being used later against me or preventing me from accessing something later?
And I would just say this is not just an esoteric idea, but there's significant research along these lines and the body of evidence looking at what are the underlying factors that serve as the foundation of medical mistrust. And of all the things that you know, in a number of studies people were given to assess, tumor or genetic profiling was ranked amongst the highest of medical mistrust in the US. So I can't say that that's true in other countries, but at least in the US studies, that ranks very highly. So that's something that we're also going to have to contend with although we know the future is genomic testing, how do we solve for that and educate patients, families, and tell them in a very honest way what is the value and what's the risk, to your point.
And I would say that is an area that FDA is leading in, and NIH as well. But FDA just in April of this year put out a guidance that requires developers of tests and drugs to come up with a diversity plan. What is your plan for enrolling a diverse, underrepresented population in your clinical trial that supports either your drug or your diagnostic? I mean, it's amazing to me that it's 2022 and we're just now doing that, but hallelujah, we're doing that, because when you have to develop a plan, you're more likely to think about the issues that are preventing you from enrolling that population and try to address it, because you now are being told by the FDA, if you want that drug or device cleared, you're gonna have to show us that you made effort to recruit that population, so that we really do have an intended use population that reflects the population that will use your drug or test.
Catherine.
While we're talking about disparities, I was amazed by some study results we had where we were looking in germline cancer testing to see whether women in safety net clinics could get access to testing. They are now able to get the testing because labs are providing free testing to these women. But what they cannot get is genetic counseling, because that's where the barrier is now. There aren't enough genetic counselors. You have to pay for genetic counselors. So we have to remember that sometimes the barriers are upstream. And so we think it's just at the point of testing, but it may be something before then, and we have to deal with that.
Yeah, I feel very strongly about this point. I could not agree with you more. If we're really going to think about the long view of genomics as a foregone conclusion of our future, we're going to have to solve for the issue of genetic counselors. You know, even just back to the cancer lens, a majority of patients are actually diagnosed out in the community. And so as testing uptake starts to increase in the community, what the community oncology practices don't have and can't afford are genetic counselors. So this gets back to how do you solve for that? So one is to create more genetic counselors, and that should likely be an emphasis, especially in the oncology community, and that has a lag, it'll take some time. There's another part of that, and that's the use of telehealth across state lines. This is something that can be deployed in a telehealth strategy. And you know, we were talking last night about some of the great things that happened during COVID when it came to differences in thinking and in true innovation in decentralized clinical trials and the use of telehealth across state lines. But this is a state decision. So as COVID has now started to ebb in our world, then we're starting to see a resumption of some of these barriers to telehealth across state lines, and this genetic counseling is a perfect example of something that would suffer from that. So, you know, this is an area where I think we probably need to be thinking in the long game about what do you do? Say you've created what you want, an opportunity for everyone to have insight into their own genetic information, but then without someone to help them truly understand what it means for them, and most importantly, the people that they're looking at every day at the dinner table, their family.
Yeah, we've sort of naturally transitioned to this topic of barriers to adoption. I wonder, Sally, what's your perspective on these? What are the most important factors that are slowing the uptake of this innovative technology?
I feel coverage and reimbursement is like number one, because otherwise it does just stay with the more wealthy, or just what did Bill Gates call us, the rich countries, I think. But those who can access it, I do think like its coverage and reimbursement is the number one barrier, and you could see that in the data that showed the use of next generation sequencing for tumor profiling and in advanced stage cancer went from less than 1% to greater than 45% right after the national coverage determination, providing coverage and reimbursement for that service. So I think that's like barrier number one. And then secondly, it's access. Access meaning the genetic counselors, all of the supporting infrastructure that allows the genomics and genomic testing to be able to roll out beyond the teaching academic centers, more toward the community health centers. And there's a lot of work that needs to go into that.
And kind of going beyond reimbursement, are there other structural factors in the health system that you think are slowing us down?
Well, I want to talk a little more about reimbursement because I'm in academia, but I've been going to these industry meetings for 10, 15 years, and every single meeting, it's reimbursement. Somebody brings it up. So, as I mentioned, I work a lot with payers, and payers do want evidence, but as some famous umpire said, it ain't nothing till I call it. And that is the view of payers in that they know the evidence when they see it as to what will lead to coverage. So understanding what payers are looking for, talking to payers, getting that evidence, and doing that very early on is really important, as opposed to at the very end of the cycle when we've got a new product and we're like, oh, whoops, we don't have the right evidence that we're looking for. So again, it's this trajectory over time that we need to think about. And in terms of the context being complicated, for example, the CPT coding system drives some of what happens. When it comes to tumor sequencing panels, for example, you have this kind of arbitrary less than 50 or more than 50 genes. I don't know where that ever came from. I don't think it's supported by evidence. But payers will say, hey, you know, there's a CPT code that says they'll pay for it if it's less than 50. So that's
Which is
what
crazy,
I'm going to go at.
Because the cost of assessing 100 genes is not different than the cost of assessing 50. So none of that really makes any sense. But when the reimbursement, though, I think we would probably all agree is not enough. So if you take what you just said, right, when there was a coverage decision about next generation sequencing for cancer patients, subsequent studies that looked at what happened saw exactly what you just said, Sally, that the uptake really was phenomenal for some. And the two groups that lagged behind were Black Americans and Hispanics. And so, even when coverage was there, they were either not being asked, which is probably some of the answer, or not feeling the trust that you talked about, Sally, to take it up.
Which I think, gets back to, I really do think that the trust issue is another big barrier to implementation. And again, I feel optimistic for a couple of reasons that trust that we are taking steps to address that issue. And one of them, again, back to the decentralized trials that happened during COVID, I really do think that because they were decentralized, we have changed. We've had a pretty fundamental shift in how both drug and device developers are recruiting populations to support their drugs and diagnostics, and they're going to a more diverse, or not just focused on the academic institutions, they're going out further and more community-based, and that does allow, there's also a virtual component now because of COVID. It allows for more diverse population, and there's been a number of papers that have come out. I know that Freenome was able to partner with Morehouse in this major study that it undertook. The PREEMPT study was a 40,000 person screening test for colorectal cancer. But partnering with Morehouse, they were able to demonstrate that it was like the 11th most enrolling site of like over 100 sites. So we have these beliefs that minorities won't participate because of this lack of trust. But when you meet them with people who look like them, who are asking them in language they can relate to participate in something that they think might benefit to them, not surprisingly, they participate. And so I think that's fantastic for creating clinical trials that will more resemble the people who will use the test. But I also believe that the knock-on effect for the future is that people who have participated in that will gain more trust in genomics, period, when it's rolled out for clinical use. So I think we will have a ripple effect from what's happened that'll be positive from COVID, just from both diverse clinical trials, diversified clinical trials, and telehealth as the other component.
Yeah, I couldn't agree more with what you just said. And in fact, the data, very strong data, indicate, at least in the cancer realm, that people of all demographics have the same response rate positively to clinical trial when asked, all of them. So this myth of someone that's from an underrepresented group will not participate in a clinical trial is exactly that. The data say exactly the opposite. So I think you're right that the asking in a way that people are receptive to hear, whether they're rural or urban or whatever the environment is, the cultural approach to discussing things like clinical trials and genomic testing probably needs to be refined in those spots. But everyone wants to participate in a clinical trial when they're asked.
Yeah.
And not to interrupt our flow here, but I want to say that we might have some time at the end of this session for some question and answers from the audience. So you could be thinking of some of the questions you'd like to ask the panelists as we get closer to the end. But let me just pick up on this idea of a barrier to adoption is somewhat on the patient side as far as the understanding of the conditions and the understanding of genomics and things like that. I was a practicing physician. How bad is the barrier? How important is the barrier for what doctors are doing? What do the doctors need to do different to make this work?
Well, you want me to
go ahead.
Well, I thought one of the speakers at one of the other sessions really said it well. This was Jay from Quest, where he was saying that we really need systems in place that make it easy and straightforward, that the information is there for physicians so that they don't have to understand genomics in any detail. It's all laid out for them in terms of what to do with it. Because I think the idea of educating physicians, I'm sorry, they do not want to be educated. Just like payers don't want to be educated either. They want it laid out in front of them in terms of what do we have, what needs to be done.
I think about this from a healthcare perspective of two totally different groups, oncology and primary care. So in oncology, where it is the case that the oncologist has a vested interest in truly wanting and needing some of that genetic information or genomic information to match patients to therapy, even then, they need the insights, not a laundry list of the 50 or 100 genes, whatever CPT code you got to use to tell you, what are potential actionable alterations and what that means and how does that match to trials within your sphere or within the range that the patient is willing to go. So this is a group that is highly motivated to implement and use genomics and genetics, and they do. But even then, they are so pressed for time on the RVU models, so they're incentivize them to see as many patients as humanly possible over a short period of time. They don't have the time to comb through this, although they are highly motivated to do so. Then on the other hand, you've got primary care, and that's really what we're talking about, right? If everything we're discussing comes to pass, and every time I walk into a clinic, irrespective of what I'm there for, people know what genetic alterations might influence my health. That's putting a lot on primary care. So I think that's a group that more than anyone is going to need to be prepared to pass the patient on to genetic counseling or pass the patient's information on to whomever the other provider is in the care continuum so that they don't have to go through and extrapolate, interpret. They need to make it essentially a good process workflow for them that makes sense with the operational workflow of a health system. Does that make sense?
It totally does, yeah. And I think that's where some of the clinical decision support work that other people have been talking about, that's just going to be, that's also foundational because you can't expect a physician to know everything or have the time to know everything. But if you can continue with the clinical decision support tools that have been, I know exist in pharmacogenomics and other places where the at least more common alleles, they'll tell you like this, go do this. But, and especially, like for cancer screening, you start screening earlier, but for whatever that pathway is, I think having that integrated into the electronic health record so that it's just seamless, that a physician will understand what to do with this information is critical. Because I know when I was at HLI, I had my sequence, I had my whole genome sequence done. We had a search tool that was developed that was like Google. You could Google your genome and you could look at it. You could look at anything you wanted. You could find and connect to different literature. That's cool. But like, I can't imagine a physician having the time to do that. Yeah. I was thankful I have a boring genome, is what I was told.
But it is good to have a boring genome.
Yeah, I didn't think of it that way, but yeah.
But, you know, real world, you know, barrier sometimes is how you can make the EHR more friendly. We can probably have a whole session on that. But just, you know, N of one person's experience in healthcare. Let's say you're working in a 16 hospital system and you want to and you have one single EHR, everybody's on Epic and all your sites, and you want to put a stop in to say, have you asked Mary when she came into the clinic whether or not she's had her mammogram because she's of this age and she has this genetic risk? The reason that's very difficult is when you have a multi-hospital system, you have many different payers, and they have very different philosophies about when Mary should have her first mammogram. And what you don't want to do is put in a stop that says, Mary, should have you have your mammogram. Oh, wait, sorry, you have fill in the blank payer, and they're not going to pay for it right now. That's, again, pushing a lot onto the provider. So if it's going to be automated in the EHR, which I think is smart, it's got to be smart automation that takes into account what someone's coverage actually is, because it's so complex. So it's not as simple as just saying, this is what our standard is for screening for somebody who's a BRCA2 patient. It just doesn't work that way yet.
I do think that was one of the, some progress that the Affordable Care Act made, though, that at least if you can get it into the AB recommendations, screening recommendations, that is a timely process. But if you can get it in there, it doesn't matter. There is no copay. Like, it has to be covered at no cost. So that is thank you, President Obama, from a couple of days ago for getting us that. Yeah.
Where does the responsibility lie, Catherine?
I was going to return back to our theme, which is data and evidence. And one thing we haven't talked as much about is the fact that sequencing is now global. We did a paper in JAMA in 2020 that showed that sequencing is available in many, many countries in almost every region of the world, other than, I think, Antarctica. So it's there, but we know very little about how the tests are being used. Who gets the testing? What do people do with it? So we've got the availability, we've got tests out there being used, but now we need data on how they're being used. So I hope everyone in this room is going to work on that.
Yeah, and I think that's really wise, because certainly we're hearing that from patients and families as genetic testing becomes more and more a component of both cancer risk stratification, but also, the genomic testing for cancer therapy is, hold on, so I'm going to give you my genetic information, and you're viewing me as a consumer of that information, and that's nice, but I'm actually the product, right? Because that genetic information is being used to monetize something, an algorithm, a treatment, or whatever. And they're not wrong. In a way, they're contributing to humanity's body of knowledge moving forward. But having answers to that of how is my genetic information going to be used, I think is a question we must be prepared to answer when we're asking someone to consent.
Yeah. And I'm going to dive in here a little bit and say, and some of the research that I've done on utilization of genetic testing for clear indications. So in pediatric patients, and now more recently we've been working on cardiomyopathies, and we can see that even the uptake of testing in those patients where there's clear guidelines and clinical indications is very, very low. So, and there's reimbursement widely available for those tests. So there's some other factors that are involved in the utilization of genomic testing that we still haven't really got our arms around. And so this leads me to kind of our another topic that we wanted to discuss, and that's about education and how we move the needle among the stakeholders in this field of medicine.
Yeah, well, I think that this is, at least in the cancer space, we've tried very hard to educate the public, but to limited success. I mean, it's confusing from the outside. You've got genetics, you've got genomics, you're throwing around these terms like somatic and germline. Yeah. What? So this is a lot to contend with. So this is where I think partnerships among stakeholders can really be very helpful so that we're all using that same pocket guide playbook for terminology for patients could be very helpful. So adopting common terms, common phraseology to talk about risk-benefit of genetic testing, genomic testing, could be very helpful for patients, and then delivering that in a way that starts early, starts young.
Yeah.
I thought that was another silver lining from COVID is all of a sudden we heard so much about genomic variants, and we heard it was just like on regular news. It was in the paper every day that you had there was a variant in this, and there was a mutation that made this not respond to vaccine or such, and we heard about antibodies and T cells, and it was like the entire country became infectious disease experts, and that's a boon to at least like some more adoption of this thing that I start to understand because I read about it in the paper every day or wherever I get my news. I'm not so afraid of, or I'm not so mystified of.
I hope you're right. But a survey done before COVID found that 2/3 of Americans had never heard the term personalized medicine. 2/3. I was shocked.
And where do you think the levers are for this education problem? Where should we be trying to put our effort to move this along?
In the cancer space, it's clearly coming in, obviously in someone who's undergoing a cancer journey and has had a cancer diagnosis is going to get a rapid fire education that they don't want. But in terms of having individuals understand their cancer risk through genomic testing, we still have a little bit of a ways to go toward that end. So I think it will take working in platforms that can be readily accessed, that can be easily understood, again, with that common language that we can all agree on. But it will also affect, and is already starting to affect, cancer screening guidelines, which increasingly will become adaptive. And it won't be just, back to Mary and her mammogram. Mary who has a BRCA2 alteration has now a very different screening plan than Mary who didn't. And so increasingly that will start to become part of the vernacular in cancer risk assessment that families will discuss, because Mary with the BRCA2 alteration is going to need to have that discussion with her daughter and her son, because it also gives a risk for advanced prostate cancer. So increasingly, these kinds of discussions, we're going to need to equip families, and we're prepared at the American Cancer Society to be part of that solution, to equip families to be their best health advocate and talk about what genomic testing means and doesn't mean when it comes to cancer risk, when it comes to behaviors that they might modify in their own lifestyle and activities, and also, of course, in cancer treatment. Now that's it. The cancer population is, I know, only one subset of those that will benefit from genomic testing. It's not all about that, but one can't help but to think, with 1 in 2 men and 1 in 3 women over their lifetime in this country getting a cancer diagnosis, that kind of discussion is going to happen at every family table.
In one area that we had talked about last night was there's a genomic education, but as much promise as the decentralized clinical trials and telehealth promise, there's also the digital divide and just digital literacy that needs to happen, because decentralized clinical trials I really do think will help us enroll underrepresented populations and also help us roll out the promise of genomics more broadly, but only if there's access to be able to have telehealth or access to the digital world. And I know there's just large populations who either don't have that access or don't know how to use it, what they have. But just another barrier that I think should not be hard to overcome.
Thank you so much, panelists. Really enjoyed the conversation. It's been great. And thank you.